Welcome to Glioblastoma, aka GBM, a podcast brought to you by the Glioblastoma Research Organization, highlighting stories of GBM warriors, caregivers, medical advisors, and more. Welcome to Season 3 of our podcast, where we delve deep into the world of glioblastoma, also known as GBM. Join us as we navigate the complexities of glioblastoma with expert insights and heartfelt narratives. Please remember that the information presented in this podcast is for educational and informational purposes only. It is not intended to treat, diagnose, or prevent any disease, and you should contact your medical provider or healthcare team with any questions. The team at IMVAX is dedicated to delivering new, personalized immunotherapy approaches to improve outcomes for people living with glioblastoma and other solid tumors. IMVAX is currently recruiting for a randomized Phase 2b clinical trial of IGV-001 in newly diagnosed glioblastoma patients. Learn more about this Phase 2b trial at imvax.com or clinicaltrials.gov. IMVAX, advancing a new approach to personalized cancer immunotherapy. Tamika and Morana, the ladies of Lenox Hill. Welcome to the Glioblastoma, aka GBM podcast. I am excited to finally be doing this with you guys.
We're happy to be here.
So
excited. Absolutely.
This is the first time that we're actually having a formal sit down that is not at a dinner in a different country or Amber's dating life related. So I am so excited to talk
Although I do want to hear about your dating life.
We'll wait till off air for that.
Fine.
It's non-existent.
Okay, fine.
That's what dinner's for after.
Yeah, okay.
So for those who don't know exactly what your roles are, I'd love for you guys to talk about your role at Lenox Hill and start from there.
Okay. You want me to start?
Sure.
Okay. So I'm the Senior Director of Clinical Research for Neurosurgery. So I basically manage all of our research portfolio. Obviously, we're on GBM podcast. We have a big focus on GBM's glioblastoma, but we also do trials for endovascular diseases. You know, we have stroke studies, subarachnoid hemorrhage, and we also do spine. Right now in our department, we're managing around 32 research studies, and 25 of them are probably interventional clinical trials. And comprised of that, we have a lot of our big sponsor-investigated studies. Our sponsor studies like our IMVAX trial. Tomorrow, we are doing our first frontier. I don't even know if I could say that, but
it's not going to come out till May.
Okay, perfect.
Yeah.
Tomorrow we're treating our first frontier patient. That's our Boston Scientific study, and it's our first intraarterial Y90 study. Northwestern is basically the main people that are doing with Roger Stoop and that whole crew over there. So tomorrow's our first patient, and it'll be number 5 or number 6 in the whole entire trial and the whole entire role. So we're really excited about that. And then we also have a lot of our investigator-initiated studies. Obviously, the one you fund, our Phase 3 intraarterial Avastin trial, and then. Yeah, so we manage everything. I'm not only the one who manages everything. There's me, I have my project manager, Sana, Sarah, Faith, our research coordinators, and then Olivia, our research nurse practitioner, and then all of our investigators that we work with. So, and Morana, our neuro-oncologist. So together we all manage a bunch of patients. Right now we have around 40 patients actively on trials, not all GBMs, but some of our other trials. But yeah, so we manage a lot of patients. We manage a lot of trials. We work with the FDA, IRB, all of that. So we are kind of like a one-stop shop, kind of mom and pop shop for everything. And we get things done. So it's kind of what we do.
Nice. And that's Tamika's spiel.
That's my spiel. I've said it multiple times.
So you got that down to a science.
I do. Interviews today, every day. I say it all the time.
I'm Morana. I'm a medical oncologist who does neuro with these folks here, part of Northwell Cancer Institute at Lenox Hill Hospital primarily, and all in collaboration with Lenox Hill Neurosurgery. So she kind of summarized everything, what we do, and I'm part of the team, one of the investigators on these trials.
We're also we are the highest enroller across Northwell Health for all cancer research. So, obviously glioblastoma is a rare disease, but we managed to be the top enroller year after year, so we're really proud of that. And, we get a lot of patients not only from our health system, but from clinicaltrials.gov. You refer patients. I just think that our program's very well known, and people reach out to us, and we're very efficient I think the best thing you could ever do for a patient is call them back immediately, respond immediately. Anytime somebody gives us a referral, we call them right away.
Well, I know every time I text you, someone's like, I'm in New York, and I'm like, I put you in, and you and Dr. Bookfar in a group chat, and I'm like, hey guys, And then you're like, we're calling them in 5 minutes.
Right.
So every single time I notice that, I'm like, honestly, you guys are the best.
Yeah, I mean, I'm glad we have a staff and we have like the resources to do that. A lot of patients, they tell us like nobody picks up the phone. You know, I've been calling a lot. Like, I mean, some of our trials, especially for our trials, like just in general, clinical trials, you have a certain window. If you don't get them in that window, they miss the window. And obviously, we want to enroll, but we also want patients to get the best treatment. And if you miss that window, you're out. So we really do a good job of screening patients, getting them in really quick because, I mean, that's really, really important for clinical trials timing.
Yeah.
And not only that, like with newly diagnosed people, when you're looking for answers from multiple sites, you want to be able to
100%.
get as much as you can in the shortest possible amount of time, because there is a time frame. Within certain time frame, you have to start certain things. So people really go all the way around. So being that responsive is extremely important. So you also give the opportunity to the other person to get the information they need, and then it's their decision what they want to do at the end of the day. But you at least give them the opportunity to give them that information as soon as possible. And being responsive and being available and not being, I don't want to say, not being pretentious, basically, about it.
Right. And we love teams. We function off of teams. So we have this huge group, GBM clinical trial chat, and it's literally like real-time updates of everything that's happening. Morana says, hey, we have a patient, can you call them, screen them, whatever it is, done. So I feel like that, I mean, literally there's probably 58 people in this chat, and it's across all of Northwell Health. So it's a lot of collaboration that people are like, hey, we just saw a new GBM. Can you get them in for clinical trial screening from North Shore, Westchester, everywhere.
Nothing frequently it happens. Like I text real time while I'm with the patient, let them know I'm letting the people know, and they call at the same time.
Yeah, we're like, hi. They're like, I'm in the office. We're like, okay, we should maybe wait 5 minutes, but
you're like, we're a little quicker.
Yes. So it's really, really important to get them in fast, especially in New York. Like people shop around, they see a lot of patients, they see a lot of people. It's not only us, but we want everybody to get all the information they can. When someone comes, even if when someone comes and they ask, hey, even people from clinicaltrials.gov, they say like, hey, I have a friend that's diagnosed with a GBM. What can you do? And we basically tell them like, we can set up a telehealth visit. We can if you're local, we can get you in right away. We need your MRI report, pathology reports, surgical reports, anything you have, CD on a disc, or send it through PowerShare, whatever it is, and then literally we can see them the next day. Whether it's a virtual appointment or an in-person visit, but timing and efficiency is really key for this disease and just helping people in general. So
when someone reaches out to a cancer center upon diagnosis and they're like, hey, I have a brain tumor, I'm not sure what it is, and you mentioned that at Lenox Hill you guys have a bunch of different trials and different sites, whereas other institutions also have different trials and different sites. As someone that's starting to navigate a glioblastoma journey, whether you're a patient yourself or you're a caregiver for a patient, how can you best advise someone, or like what are steps that someone should, I guess, take to say like, this is the institution that I'm going to, and what do you feel like brings people to a particular institution? Because again, if these trials are offered at different sites, like, would you say more of the research team and the physician team that is bringing people to the center, or what do you feel like makes that big difference to bring patients in?
For us, we are open. If you feel comfortable with your local neuro-oncologist or your local radiation doc, obviously you're going to radiation 5 days a week. You can stay there. For us, it's like where you feel most comfortable, and then they get brought in. Like we're kind of special for our clinical research program. Is most of other institutions, their clinical trials are housed in neuro-oncology specifically. For us, it's in neurosurgery. So we see them at the very beginning. So for basically our IMVAX trial, like we know exactly when they're coming because we see them. All of our trials are mostly housed with us, and they can see us like from beginning to end. So when patients are choosing clinical trials, yes, I do think it's the team, a team approach. Like obviously, John is great at talking to patients, even if he doesn't does the surgery. Like he's very open to basically like, here, this is what we can offer you, other places you can't offer. We don't discourage anybody from going anywhere else ever. I feel like if you think something else is better for you, if you think a better neuro-oncologist, radiation doctor is good for you, that's fine. But you can still see us, and we can be like home base for you, and you go wherever else you need.
I 100% agree with that. I think at the end of the day is what the connection.
Yeah.
Because you're going to get multiple different trial options in multiple different institutions. So if there's a really trial that you feel fits you, that's the one you go for. But let's say all trials being equal to you, nothing really fits, or maybe all of them fit. It's at the end of the day, the connection and where you feel like most comfortable. And I think that's very important because you have to be able to trust your clinical team
Yeah, that's exactly what I
on
was
a
gonna
lot
say.
of levels.
Well, that's my next question.
Yeah,
Like,
it's
is it,
trust.
I'm a patient, and you said, like, sometimes patients have multiple trial
Yeah.
opportunities or matches. In that situation, you as a neuro-oncologist, are you saying, like, hey, I think this might be the best option for you? Do you kind of, like, leave it up to the patient and their family to, like, see what they're comfortable with? Like, how does that work?
I actually take my time and go over each and every single option and tell them why I think each and every single one would be good versus not good.
Yeah.
Okay.
Because I try to understand, even if it's not our institution, I try to maybe understand what's the hypothesis behind it, how does it work, and then we kind of go over it. Because it is my role to guide them. Nobody should feel like they're without guidance. So I try to understand what's really the mechanism that they're trying to investigate. And I think that's the role of every single healthcare provider that's dealing with this disease. And then whatever they choose, it's the right choice for them at the end of the day. But
Yeah. I mean, it's definitely a discussion. And we have a lot of trials, and we're very special, unique, that we can offer basically a trial at every stage in their disease process. So, patients who come in for surgery, we have surgical trials. And if you're not ready to sign a consent, then we say, don't worry about it. Wait until after surgery, and we have more options for you. Then, we have for newly diagnosed, we have like our MVAX trial. So if you don't, our MVAX and our surgical tissue flap up front. If you don't feel comfortable, then you say, okay, fine, wait a month until you start chemoradiation. Before you start chemoradiation, we approach them again, or if they want to talk about clinical trials, we're like, hey, you can do our intra-arterial Avastin trial, intra-arterial cetuximab trial, or our Cantex trial, aziliragon. So we're like, and if they have their options, some patients, the intra-arterial trials, you have to go under anesthesia, and they're like, oh, I don't feel comfortable with that, or maybe they're not healthy enough for that. We're like, okay, well, if you're this, and obviously all of these trials have specific inclusion-exclusion criteria. Like cetuximab, you have to be EGFR amplified. Our aziliragon, you have to be MGMT unmethylated. So some of them, they just, they'll get excluded on their own. And then after that, if they're still not ready, you can go on, and then after their 6 weeks chemoradiation and they're ready again, you can go on our CAPTUM trial. And then the Cervax-M, it just closed for enrollment, but that's another option. So we can offer someone at any point and anyone and a lot of patients don't get to us until after they've started chemoradiation. But we said, don't feel like you missed out on anything. We have other options for you.
Yeah.
And then, even in the recurrent setting, we have other options. So don't feel like you're tied into one trial. And I feel like a lot of patients feel pressure to make a decision, but we're like, you don't have to make a decision right now. Obviously we are going to recommend what we think is best for you, but if it's too much, don't worry about it. There's other options.
Yeah.
And then there's standard of care. If you want to do standard of care, we're all on board. If you just want to do standard of care, you do that. Obviously, we encourage clinical trials because we believe in them, but we're never going to force anybody into doing a trial if they're not ready for it.
Correct. It needs to feel right.
Yes.
Yeah.
That's key.
Yeah.
And backtracking, so anyone in the audience that doesn't know about clinical trials and the process of how that works.
Yes.
For example, IRB. What is IRB?
Oh, okay.
Let's start from like baseline.
This is my specialty. Okay. So IRB. So I've been working with Dr. Bookmeyer for the last 13 years. We started at Cornell together in 2011. So I've been doing IRB stuff since 2011, which is a decent amount of time. So I feel like I kind of know what I'm doing by this time. But so the Institutional Review Board is our governing body of what we can do for patients. We cannot do anything without IRB approval, institution approval, and if we are giving an investigational drug or a device, obviously we have the FDA involved. So the first step is that if you're doing anything investigational with a drug, you go to the FDA, you get an IND. If you had an IND approval, then you can apply to go to the IRB.
If someone does something on compassionate use, does it also run through IRB?
That's institutional. It depends on the institution. For us, for example, Project Facilitate, which is amazing for rare diseases. If you go through Project Facilitate, get approval from Project, which is the part of the FDA. You get approval as compassionate use, but it's for oncology compassionate use.
Got it.
It's great. It's a great program for anybody, investigators out there who ever want to use that program. Literally, they're great. It's from part of the FDA. Anytime you call them, they pick up the phone.
Really?
Like, I've never met another governing body that they always pick up the phone. They're amazing.
And what is their name again?
Project Facilitate.
Project Facilitate.
Yes.
Okay.
They highly recommend it. And I don't work for the FDA, but they're great.
Got it.
So that's my disclosure. I don't work for the FDA. But so if you do a compassionate use or emergency use through them, you get approval from them. And then for our IRB, you tell the IRB after you treat the patient. You tell the IRB after you treat the patient. They don't need to know before, since the FDA knows. But different institutions have different rules on that. So you would have to check with your institution for that. So once you have that, for Northwell, we have our disease management team, which is our internal kind of review board, So first, the protocol has to be vetted by the disease management team. After disease management team, then it goes to our protocol review monitoring committee, which is a bigger cancer committee, so they have to review. So there's a lot of layers of approvals that protocols go through, and then you're allowed to go to the IRB. Then you do contract budgets and all of that. So, and then once the IRB tells you, hey, yes, there's different reviewers that review it, whether it's a surgeon, a layman person, whatever, whoever, different IRBs. It's comprised of different boards, but. And then once you have that approval, you have institutional approval with what we do. That's just an institution thing. And then you can finally enroll your patient once you have that. So that's and they basically govern. Like, if anything, adverse events, you have to tell them, you have to tell the FDA. And most protocols, you have to get renewal every year. You have to basically tell them the status of what you're doing for your all of your protocols, your clinical trials, and then. Yeah, that's kind of like how the IRB works. There's a lot of people looking at these clinical trials. It's just not like, hey, I wrote this, I got it approved. It's not that. There's a lot of people vetting this and saying, hey, yes, this is safe. We believe in this. Mostly it's safe. Is this safe to be treated for patients? No one's going to do anything unsafe, and nobody's going to put an institution or any patients at risk. At least we don't do that. Yeah. So, yeah.
And when you say protocol, just listening, it's... A protocol is essentially the trial itself.
A protocol is the trial. It basically outlines everything that is happening. So, you have your it starts with like your summary. You have your study endpoints, safety, schedule events, what's happening, background, rationale. It's basically outlines what you're doing and what your endpoint is, what you want. There's stats are involved. It's not only us writing the protocol. You have to have a statistician look at it. Like, you can't just say, hey, I'm going to enroll 10 patients in this or something like that. You have to have other people looking at this, So there's a lot of layers of writing a protocol. And, we're special that we also write our own protocols. We're the holders of the INDs. We're writing the protocols. We're the ones working with the FDA for our investigator-initiated stuff. But it's a lot of work. We're building our REDCap databases. We are doing data collection. We're analyzing data. Today we got our flap. We did a actually like 10 patient trial using our surgical tissue flap that just got approved by the Journal of Neuro-Oncology.
What does that mean? What's a surgical tissue flap?
So basically the surgical tissue flap. So we have a lot of surgical
You're
trials.
You're like an encyclopedia of knowledge. This is great.
Am I talking too fast?
No, you're good.
I am? Okay, because I feel like I just talk.
It's because you're from Miami and you live in New York.
I just live in New York. It's just like fast.
It happens.
So the surgical so the problem with glioblastoma in any brain tumor is that you have your blood-brain barrier. Your blood-brain barrier obviously is there because it protects your brain. But when you have a glioblastoma, you don't want it's there, but drugs can't get in. So basically, our whole research portfolio is how do we bypass the blood-brain barrier. So you need small molecules for drugs. That's why Temodar is basically the only drug on the market because it's small. You can add more about Temodar if you want to, but the gist of it.
Standard.
Yeah, kind of standard, and that's the only other thing. And a lot of stuff doesn't work. So we try and bypass the blood-brain barrier. So for our surgical tissue flap trial, basically we take a piece of pericranium, which is like on your skull, and when you see them, John does it. Basically, you kind of like it's basically like he explains it better. It's like the skin on top of your skull. So basically it's a vascularized tissue flap, right? So what we want to do is we place that into the brain. So they have surgery and they harvest it first before, they open up the skull and everything. So
How does that happen?
What, like the harvesting? Okay, so basically
during the surgery.
I feel like we're on like a.
I have pictures. They open and they basically kind of scrape off of the tissue.
Okay.
And this is done for a lot of other things. So they kind of like nudge off the tissue, right? And then they like put that to the side, right? It's kind of like they wrap it up in a little it looks like a little Tootsie Roll. They wrap up, put it to the side.
Got it.
They do the operation, clean it out, and then
call it the Tootsie Roll trial.
They put the Tootsie Roll to the side.
Yeah.
And then, they take out the brain tumor, and then if it's a high-grade glioma, glioblastoma, then we can proceed. So there's also like steps. So obviously we're never going to do anything if we have to confirm with pathology if it's a high grade. Then, so basically we lay the pericranium into the cavity, and we hope that vascularized tissue will basically bring a blood supply into the brain tumor cavity, which will get drugs into it faster, and effectively. Like instead of having, so we basically just published and got approved from the Journal of Neuro-Oncology that trial.
Congrats.
So that we are now in our phase 2 portion of the trial. So we'll see what happens. That believe that has like 32 subjects. So we did our first pilot, which has 10. We had to add more, so it's actually 12 evaluable subjects, or kind of evaluable subjects that we did. So we'll see how that goes. So we have, and then bypassing the blood-brain barrier, that's our intraarterial trials. Chemotherapy is given IV. Instead of giving it IV, we deliver Avastin and cetuximab intraarterially. So basically, like they snake a catheter and they see what arteries are supplying the brain tumor, and then we deliver it directly into the brain tumor cavity through that. So that's another way to bypass the blood-brain barrier. So that's another big component of our research trials.
Well, Morana, a question for you. As a neuro-oncologist, pathology sometimes takes a while to come back. So I'd say someone comes right out of surgery. I guess every institution is different, but what is a standard timeline of pathology reports to come back? But also, as a neuro-oncologist, like in that time, you are sort of making the decision with the patient as to like what the treatment plan is. But how do you do that if you don't have the pathology yet?
Well, typically they would tell you if it's a high-grade glioma very quickly.
Okay.
So I would say probably 24 to 48 hours they would be able to say if it's a high-grade glioma.
Okay.
Let's say in our institution, I think 3 days is probably the standard turnaround time for like the first path type of thing.
Well, it's so interesting you say that because I feel like I've talked to a lot of people, interestingly enough, in the last like week that have gone through some type of surgery and that it's like I'm still waiting for my pathology, and it's like weeks. And I think that's so interesting that it takes such a long time.
When it's a complicated more case where you don't know if it's like a grade 3 or you're still waiting for some molecular testing, so next generation sequencing, which will help you literally upgrade somebody or not. But as long as you know it's like a high grade glioma, so what that means a grade 3 or 4, typically the standard of care treatment would be always the same, which is basically Temodar with your radiation therapy followed by Temodar. Now, question about trials really cannot even be raised until you have that final pathology.
Got it.
But standard of care would be the same for like any high-grade glioma, and that we would get pretty quickly. I do not foresee any institution having that, like, oh, we have no idea if it's a metastasis versus a primary brain tumor. That's it would be very odd for that to happen. But what Tamika was saying with the blood-brain barrier disruption, that's like really, really key. Because if you think about it, like as somebody who was trained in Med-Onc, it's like, look at our lung cancer, right? We have this targeted therapy where it's like really mutation-driven. You do the molecular testing, you give one pill goes to the brain with like 85% efficacy in the brain, excellent progression-free survivals, overall survivals, things like that. You have the immunotherapies that also work. You have the chemo that works. With the GBM, it's like typically a hypermutated tumor that has all these chromosomal aberrations. Typically, they need an alkylating agent, and targeted therapy by itself doesn't work. So then you got to choose.
What is an alkylating agent?
Alkylating agent means chemo. Targeted therapy means basically typically an oral pill that is a small molecule and can go through this blood-brain barrier. Alkylating agent, it's a chemo of some sort, like Temodar. Temodar is example of an alkylating agent. CCNU is an example of an alkylating agent. So these agents, for example, Tamidar goes to the brain well, but majority of them really don't, because of the tightness of the blood-brain barrier. So that's why this blood-brain barrier disruption, all the trials, the way they're designed, it's like really key component. And then down the line, when you're thinking about your recurrent setting, what you're going to give the patient, like either CCNU or whatnot, you're going to give.
What is CCNU?
Lomustine.
Okay.
Yeah, lomustine, standard of care, like second line, or any other alkylating agent or chemotherapy. You really have to. You choose based on what you think goes into the brain, and if there's data or reports, what's the IC50, so the concentration that you can find in the cerebral spinal fluid, things like that. You really try to choose an agent that goes into the brain.
Not on a clinical trial, what do you think is the best drug for recurrent GBM?
There is no such
I know,
thing.
but what would you pick? If there's no clinical trials exist, which one are you picking?
Well, standard of care would be definitely lomustine, but that's it.
Right. And that's it.
Yeah.
So that's why trials are really, really important, especially for recurrence. Like,
do you feel like, I mean, you've been doing this for 13 years. And okay, so actually backtrack. Why did both of you get into this field?
For me, it goes on a personal level. And I think you and I spoke about this. When I was in med school, my first year of med school, actually, my brother, he was 21 at the time, was diagnosed with an anaplastic ependymoma of the cerebellum that actually was like a glioblastoma. It's like the weirdest possible pathology, very aggressive tumor. And
have you seen that pathology again in your practice?
No.
Interesting.
Not ever.
Wow.
Like an anaplastic ependymoma, yes, but one that is so aggressive that they were calling it like as a glioblastoma. Initially, honestly, it was just typical anaplastic ependymoma, EMS stain. That's like a stain you do under pathology. Was like typical. But he got standard of care treatment, great gross total resection.
So standard of care with chemo, same? Yeah.
So he was actually operated by Dr. Vinko Dolent back in Slovenia, who's like one of the major neurosurgeons in the world. He created, I think, the cover nose approach. What's the skull base approach, something like decades ago. He did like a lot of very important things. Anyways, he was operated on chemo RT, then got Tamidar. He was methylated as well. Then he recurred actually in the spinal cord, in the cervical spine, at which point basically, well, they really had no good options. So we started looking around, and I was shopping around a lot. And you know what helped me? Virtualtrials.org. The Mozilla Foundation existed back then. That was 15 years ago, I mind you. So that helped us find a bunch of institutions, including MSK with Andy Lassman, Roger Stoop. So we went all over to them. And he then got treatment with Avastin and irinotecan and had a great response initially, and then he progressed again, and then he was on a bunch of off-label things. However, he passed away 2 years almost after diagnosis, just before his 23rd birthday. So the reason why I went into this is I went to med school with the idea I would be a psychiatrist like my mom, who's an MD PhD, but then I couldn't see myself doing anything else. And A, this is the only thing that really interested me. B, I promised my brother I would do this. I promised him I would do this. I wanted to make a change, but not only in the research sphere, moving the field forward, but also I didn't want anybody to go through what me and my family had to go through, because when it comes to your practitioners being dismissive of your concerns, I know what it feels like. Like my mom is a doctor, as I mentioned, and like after my brother recurred, they would grab her and me in a corner, like put us in a corner and say, you know, he's gonna die in 4 weeks. Not here.
They said that to you?
Yeah, back in Europe. He's gonna die in 4 weeks. They were telling us.
How did you react to that?
We were just quiet, didn't say anything, and then I just grabbed my mom and said, let's go. And then we were on the next plane. And we came to New York. We went to see a bunch of people. And we found hope. So nobody was giving us hope back then, except for the people we met here. So Andy Lassman, Roger Stoop. Do
you feel like the quality of patient-physician communication has changed now knowing, I guess, the partners that you guys have in Europe, do you feel like that's changed any?
I think it has improved on a lot of levels. I still think that it has a lot of ways to go. So that's why with interactions with my patients and their family members, for me, it's extremely important for them to know that I'm available. I'll give my patients my phone number. I give them my cell. Like we were just chatting, like when somebody has
the
an
Lenox
issue,
team
they
just
call.
hands out the
And I
phone
have
numbers.
to say, our
They have to call
patients
me.
love Morana.
Yeah.
I mean, they not only like with them as the patient, but their caregivers, their daughters, whatever. Morana, everybody loves her. I mean, she's always available, and she just cares for everybody, not only the patient, everybody who's involved in their care. So yeah, it's definitely a testament for what you've gone through and how you are now. So.
Yeah, I mean, this changes you significantly.
Yeah.
Like it flips your world upside down completely. Like my son, his name is Borut Jr. My brother's name is Borut, clearly. My mom, dad, and me, we have the same tattoo on our backs with their names
And
on
it's a
it.
significant tattoo too.
Like it's a big tattoo.
It's a big tattoo.
With their names on our backs.
Okay.
All three of us, the same.
Okay.
Like my
Did that hurt?
80-something-year-old dad.
It's like, what is
and
it?
my
What is it
60-something-year-old
again?
wife.
It's like what is it? Like I know, but what is it? I know, but
Their names.
I know, but isn't there like a
No, it's
something?
just their names.
there was a
It's, like,
dragon?
very
I mean, it just
artistic.
it's like
looks
very it looks
artistic.
very artistic.
It looks artistic.
Okay.
Yes.
Yeah.
So there's no dragon.
No, there's no dragon. There's no dragon.
I used to look at it in tumor board. I was like, oh, there's Morana. I see her tattoo.
Back.
When we used to have tumor board in person.
So
Morana,
we know each other since I was an intern, by the way.
what year did you start? You not that much longer
When
after
did you join Lenox?
I got there in 2014.
A few years after that.
Yeah, it's our 10-year anniversary. So yes,
congratulations.
10-year anniversary. So 2014. Duh.
A couple
Yeah,
years after that.
20. Yeah, probably like 20.
2016.
Yeah,
15,
like 2 years.
15?
Yeah, you're right. Yeah.
Something like that.
So I've known me and Morana have known each other for a very long time.
Yeah.
Amazing.
Yeah.
And then, so how'd you get into everything?
You know when a profession chooses you and you don't choose it, and you just that's me. I'm from Miami. I went to undergrad at University of Florida, and then I worked at like in a Alzheimer's or something lab, and I would just count dendrites or something like that. I didn't know what I was counting. I probably messed up all of the results because I was like, I couldn't see anything. And then I came to New York. I went to NYU to do my master's in public health, and then my friend from Miami also, she was working at Circle Line Cruises, and she's like, oh, Meeks, I do a cruise for the Children's Brain Tumor Foundation. Like, they're looking for someone who does grants, like who wants to do grants or like part-time. Would you be interested? I was like, yeah, sure. I'm like, so I started working at the Children's Brain Tumor Foundation. I did programs, I did grants for them.
Wait, I didn't know you worked there.
Yeah, I did. Yeah,
No way.
Yeah, I worked there from 2008, 2007 to 2010.
Oh, I had
and
no
that's when
idea.
I met Dr. Swadan. He was on their board.
Mm-hmm.
And then when I finished my master's, he was at Cornell. And then he must have told me, hey, there's a research coordinator position open or something like that. And then I interviewed over there. And that's when John was a baby back then. We actually talked about this. When I met John, he was like 35-ish, how old was he? He's 50, whatever. But he was young.
He's
so this was 40.
He's gonna get mad. That's what comments
I
are.
don't even know
You're
what
gonna be in trouble, Tamika.
I know.
You're going to get
So
yourself in trouble.
Then I know, right? I am going to get in trouble putting out everyone's age out. And then I ended up working. I worked at Cornell. That's how I met John. And then when John was leaving to Lenox Hill, at that point, I did my master's in public health, and I was like, oh, I want to do something more public healthy or something like that. So I was applying for jobs. Like I had a job at the Department of Health. I had a job at the Bronx VA. And that's when John was leaving to come to Lenox, and he wanted me to go with him. I was like, oh, no, I'm trying to get out of like brain tumors, GBMs. Like, I want to do like something else. And then, he was like, oh, you're going to go work. You're going to go do that. There was like a study, it was like an asthma study looking at the correlation between asthma and, cockroach infestation. He's like, oh, you think you're going to be good at, you think you're going to like that? So obviously, and here I am. I stayed with him, and 10 years later, we're still here. And I love it. I couldn't imagine me doing anything else, and I would never. I love GBMs. I like our team, and I like studying what we do, and I'm invested. When you see a program grow, from 10 years ago to now, I can't imagine doing anything else. And even even my girls that work with me, I mean, they love cancer, they love GBM. I know it's like weird to say you love it, but I mean, we're passionate about it, and I can't imagine me doing anything else. And I love research, and I love regulatory, I love IRB, I love starting things up.
You like taking care of people.
I like
and making sure they get better and some hope.
Yes.
So, like, what is your interaction with patients?
It depends. Like, it depends. Like, my coordinators, they have a lot. They're making sure their appointments, scheduling MRIs, data follow up, making sure like John and Olivia, Morana, everyone's saying like, hey, record the KPS, you do neurophysical, all of this stuff. So, it depends. If like I connect with them at the beginning, I'll like kind of, but I see a lot of patients, I'm there for a lot of like the initial like, hey, like what should they do? We look at scans together and I'm like, oh yeah, I think they would be a good IAVS. And I think they would like, why don't we put them on this, kind of like that conversation. So obviously I have a lot of other things to do, so I can't see them all, but I get it. Some patients you get really attached to, and everyone has their little pockets, and we've set up kind of our research program. There's like a main coordinator, and that's their trial. And then, everyone else is backup. But once you're on that trial, they kind of have a lot of interaction with those patients. So, they have their little like pod of patients that they love. And then I pick who I love and, I connect with. So, sometimes you see them, you just see them more,
Yeah. If like, I guess looking back on the last 10 years of both of you being at Lenox Hill.
Yeah.
Where do you think this question's going?
I don't know.
Like, nostalgic?
I don't know. It's been a long time. I mean, I feel like I am nostalgic.
We're getting old.
I know.
It's okay.
Like, what has changed in the program since you started, and where do you feel like the next 10 years are going to take the institution?
From our program perspective, we've come a long way, and I have...
And this is for both of you.
It was Lenox kind of wasn't a research, especially a cancer research hospital.
I remember.
It wasn't. So we've had a lot of growing pains, but I honestly like Feinstein, Northwell, Lenox have been really, really supportive of our program. Like the other day we were on a call with how many people for SonoCloud? Maybe like 12 people, whether it's like nursing, chemo pharmacy, research pharmacy, lab, like
and it's just our internal team to talk about something.
Like I feel like everyone is very, very collaborative and really invested in research, and they will do a lot for us. And I'm so appreciative of our whole team, our whole hospital, of what we can come together and do. And I it's just really amazing. And I feel like in bigger hospitals, I don't feel like that collaboration is there as much. I do feel like us being very close to one another, and just like proximity wise also, just like we're all there.
But personality wise, like I've had at this point probably every single person on the Lenox Hill team.
Yes.
After this week I will have had like the core team, and everyone is like super, like every time someone's on the show they always say like we're super close, we're super tight knit, and like you can tell like all your personalities are like they mesh like perfectly.
We do, yeah, I do. Obviously,
again, things happen every day.
I'm
saying like
different
personalities, like a broad overview from the outside. Like it looks like you guys are like the neurosurgery Brady Bunch.
I think we all.
I've never seen the Brady Bunch, so.
Yeah, I think we all appreciate and respect each other a lot.
Yeah.
And sometimes we have differing opinions of this or that, but I do feel like everybody we really respect each other.
Yeah.
And sometimes we don't agree on things. We don't, but I think we're all, in it for our patients and to make our program the best program. We can't do that if we're not all on the same page. So we're, on a broad level, we're all on the same page of what we want to do and what we want to achieve. So I think we've come a long way. In the next 10 years, I honestly just think that our program's going to grow even more. There's a lot of really cool trials that we are doing that we can do. And, we had meetings today at Feinstein. It's like, even we collaborate with people at Feinstein. We collaborate with people at Cold Spring Harbor. So I think in our kind of realm, we have a lot of people that are not even in GBMs. Like we talked to this, he does cardiology, he does, vagus nerve stimulation. So there's a lot of people that are just like, hey, well, I do this, you do this. Like, why don't we collaborate and do something, because it just makes sense. So I think everyone is really into collaboration and just doing cool things. Like if we're going to invest and do something, like let's go big. Like we're dealing with GBM. We're not going to collect data and figure something out. Like it's not going to work like that. So.
Yeah. Exactly. And the important thing about Lenox is, and I've done all my training at Lenox, so I can say this, it's really like a big family. And you don't see that in other places, I think. At least I have not felt it in other places because we know each other so well. Like my phone is like full of phone numbers from everybody from the hospital. And whenever you need something or you're not sure of something, you can call somebody. Just phone a friend. They'll pick up on you anytime, like weekend, at night, text, anything you need. And I think that's very important also for like patient care, for clinical trials, because we help each other. We're going to help each other make things happen, be efficient in making things happen. So looking at 10 years ahead, I think we have a long way to go in this world in general, like glioblastoma world. There is a lot of very cool things coming up that we're all very psyched about. It's going to be a lot about also looking into more information is like, why does this GBM respond to this versus not to this? Getting a lot of tissue information as well. But I think with the team we have set, it's a bright future ahead.
Yeah, and even with like John's, our Brain Tumor Biotech Summit, I do feel like events like that when a lot of different people are in one room really makes a difference. Like even when you have patients, you have biotech, you have investors. Like we all want to gain something out of it. We all want to help patients. So I think
it was an amazing event,
right? So I do think like that in itself, like more of that, more collaboration, more integration is really what our future is. So and it's happening, and it's already happening. I mean, every day. So I think that it's. We'll see what happens.
And it's good that nobody is like really territorial, not only like within Lenox Hill, but also outside institutions, like just talking to colleagues. And like I have colleagues at other institutions that are like open to collaboration. And it's like, it's a very cool thing. It's a very cool thing to do because at the end of the day, we're trying to move the field forward. And if we put our heads together, I think it's going to be much easier.
Yeah. I mean, Terry at NYU that works with Dan Oranger. Like we talk about our patients all the time. We're like, oh yeah, that one went to you. We saw him yesterday. It's like a funny thing though. It's like, listen, you have to feel comfortable. Wherever patients want to go, that's where you feel right. You can't force anybody to stay with you. But I mean, it's just, we're fine with it. Like you have to do what's right for you. So we're not territorial at all. Like
and patients always ask, like, if I were, so the typical question I get is like, if I were your family member, where would you go for a second opinion within New York? And I give them names.
Who do you give?
Like of the people I work with.
I want to know the names.
I give Rebecca's name.
Okay.
Yeah. I love
She'll
Rebecca.
be at our summit.
I love Rebecca.
Okay.
But then they ask me, what about outside of New York? And I'll say, go to Roger Stoop, go to Andy Lastman. Or New York, I go to Andy Lastman, go to Fabio. Like literally, because it's kind of hard as a patient, right? Like you got to Google and it's like Googling the top neuro-oncologist in New York or the top brain tumor center.
And then there's like sponsored ads. And
correct.
That's like, how do you actually
navigate that?
That's
like,
hard. Yeah.
So like just being able to ask one person.
My dad, like I wasn't involved from the first, 75% of his brain tumor journey, but I wish I could ask him. I have no idea. But I have no idea how he found his doctor. And his doctor was awful, horrific human. I remember literally horrible. This guy was nuts. My dad was he had a gamma tile. No, gamma knife. Gamma knife. We love Gamma Tile. They're a sponsor of the podcast. He had a gamma knife, and he was in a parking lot waiting for my mom and I to come pick him up in the car. Just finished like his treatment, and the doctor like revs into the parking lot. 50 miles an hour, and then like my dad's just like in the wheelchair, and this guy like stops short like a couple inches of my dad. My dad was like,
well,
no, that was just, he's also like not a nice person. My dad was just like, his daughter was about to run him over in the parking lot.
Yeah.
Nuts. Well, anyways.
It's important to have a resource of who to ask. Like I can tell you, like I said that I really looked into where to take my brother back in the day.
Yeah.
Like I remember.
What did you do? I mean, how did you find that? Because back then you didn't have the knowledge you know now.
I was a first year med school student. I figured it out. I was awake day and night to figure out things because my parents couldn't because my brother was sick, and I literally was searching until I found a few names, and we were fortunate to find a very few good names. We did find some I'm not going to say the name, a doctor
Yeah.
back in Europe from Italy that like he was direct. He knew what he was doing, but like he was very dismissive of my dad. I remember my dad being very distressed, saying like in an email, in a patient who's hemiparetic with this and this, there's
What is
no option.
hemiparetic?
Not being able to almost not being able to move half your body.
Okay.
So like in a patient who's hemiparetic, he has no options left, things like that. And my dad was very distressed about it. My dad he's 85 now. I don't even know how old my dad anymore is. He's like the best dad in the world. But like he's such a decisive person, extremely successful. He was in management his whole life. He led hotels for intercontinental hotels. And that was very distressing for him because like somebody telling him, oh, your son is not going to do well. Oh, your son is going to die. There's nothing you can do. He would not accept no for an answer.
Right.
And we were just, me, my mom, and my dad were just kind of huddling what to do next, who to go to next. Let's just do it. Whatever it takes, we're just going to do it. And we did it back in the day. It was hard 15 years ago. I think it's easier now because of the social media.
Yeah, absolutely.
You actually have forums. You have
Right.
as I said, the Mozilla Foundation. You have your site. You have a bunch of other resources which 15 years ago weren't available.
Right.
Right.
But I think just gathering information from all these resources together and just starting. Start somewhere. Like don't sit on it for like a week and say, this person, I like their picture. No, don't do that. Just like go somewhere, go to one person, then ask them where would they go. Because,
Right.
you might run into an asshole who will say,
It's true. Yeah.
whatever.
Yeah.
You might run into actually a normal person like Tamika, and Tamika will tell you, listen, this is this person, this is this person, go to this person. So you're going to run into some good people on the way. You're going to run into some bad people on the way. You just have to start somewhere and make a decision.
And I have like some of our patients like in like more rural areas, like they don't have a specific neuro-oncologist.
Yeah.
Right.
They have oncologists, not that they just don't know what else is out
Right.
there.
Yeah.
So I do think it's important just finding the right person, whether, you're calling around, but it's a lot of information. Like we have patients, that calls were like, I don't know what to do. Like they just don't know. Like they got referred to oncology, but it's a regular oncologist. They said, oh, standard of care chemo RT, and that's it. But they know like there's more out there, but it's just how to navigate that. And we really do our best of, whether it's like a quick telehealth, say like, hey, send us our scans, let us guide you.
Yeah.
Let us like just, if you're on the right direction. And, some patients just calls me like, even if there's nothing else they can do, just having a reassurance if John says, you know what, you're doing the right thing.
Yeah.
This is what I would do. And they said, you know what, it makes me feel better because I don't know what the right thing is.
Right.
So even saying standard of care, like I would do the same thing.
Yeah.
So we just kind of, even if they don't enroll on a clinical trial, some people, they're not eligible and it's not right for them.
Right.
But just having someone else say like, it's okay, like, that's the right decision. You're being a good caregiver.
Yeah.
And it's right. So
Yeah. And I appreciate both of you sharing your insights. I feel like the information that you've just talked about will be helpful to a lot of people, whether they're patient, caregiver, or someone that's just interested in learning more about what clinical trials are and neuro-oncology in general. But before we wrap up, a question for both of you is that if you could give one sort of statement of hope or support to anyone that's listening that's going through a GBM journey right now, what would you say?
Don't Google too much information of the prognosis because it will only make you sad. Because you don't know where you're going to be on that bell curve. Right. There is some people, few of them, that do well for a long time, and you don't know if you're going to be one of them. So don't trust the statistics too much because if I can say this, my brother had a diagnosis that was less than 1%, and it spread into an area that was less than 1% chance. So like if those bad things can happen when the statistics are so low, I think good things can happen as well when the statistics are bad. So just have faith, have hope. Don't let anybody take your hope away because it's the right thing to have hope.
yeah, I agree with that. Like when you Google, like even when we talk about data, like prior to the WHO classification, change. I mean, data is going to be different, and data is going to change between IDH mutant and IDH wild type. So whatever you're seeing now, I think the framework of that is going to be different. So we're better for worse, but it don't Google. I mean, there's so many factors of so many. I mean, we have patients. I mean, we still have patients that have been living a longer time than anybody would expect, and we specifically don't know why, whether it's a child, so you don't know what your prognosis is going to be. And I just think that a lot of people don't think they have options. But there are options, and there's different options, and the more you just kind of talk to other people, clinicaltrials.gov, just do a little research, and then once obviously call us and we'll help you. So I think that research is on a good pathway to have more of a significant change than we've seen. And I think that is due to technology, surgery, everything. I do think it's on an up curve rather than a down curve. And I don't think it's gonna plateau. I think it's gonna increase. So
and if someone wants to get in touch with you guys, or someone that wants to have a consultation, what do they do? How do they find you?
Well, a lot of people find John on Instagram because he's a Netflix star. So Jay Bookvar, Instagram. Okay. And then you could always email us. We literally get a lot of patients that I'll get an email and it's like, hi, I DM'd Dr. Bookvar on Instagram. He told me to email you. And I'm like, okay. So obviously you can always email me my information, twong4@northwell.edu.
I'll also add it into the comments for anyone that wants to check it out.
You can go on our website, Morana. We're all available. Yeah. So if you send us an email, someone will respond right away.
You can email me anytime. Yep. Vojnic@northwell.edu.
Awesome.
Yes. Yeah, always respond.
Well, thank you both for coming on the podcast. I feel like it was so long overdue.
I know.
But I'm excited to be able to share this, and I think it's really insightful and helpful to a lot of people. So
amazing.
Thank you.
Thank you for having us.
Thank you for tuning in to another episode of Glioblastoma, aka GBM. To learn more about the Glioblastoma Research Organization, you can visit us online at gbmresearch.org, on Instagram or Facebook at Glioblastoma Research, on Twitter at glioblastoma.org, or on LinkedIn as Glioblastoma Research Organization. To start your own fundraiser, to donate, or to learn how to get more involved with the organization, please email us at contact@gbmresearch.org, and we'll see you on the next episode of Glioblastoma, aka GBM.